Good morning. I would like to first thank the SOLS Organizing Committee for inviting me to speak on a timely topic assessing the role of subthreshold laser therapy in the current anti-VEGF era. I apologize that due to an unforeseen scheduling conflict, I could not be actively present with you this morning during this webinar. In future, I will look forward to meeting you all in a more interactive pattern. Here are my relevant financial disclosures. In this presentation, I will be addressing the topic in 4 sections. First, I will share a brief reality check derived from the real-world data as provided by the Preferences and Trends, the PAT surveys from the American Society of Retina Specialists. Second, we will review the retinal and specifically macular conditions that are currently managed by both anti-VEGF therapy and subthreshold laser. I will then share a few representative personal clinical cases illustrating the advantages of integrating STL and pharmacotherapy. Finally, I will present a summary of the use of STL in the current pharmacotherapy-laden environment we now face. So first, the reality check. The big question for all of us is really whether laser treatment is becoming more obsolete in light of the ever-expanding pharmacotherapeutic options for dealing with macular diseases. Looking at the PAT surveys, which most of you are very familiar with, for the past 5 years in particular, you can see our retina colleagues see the role of laser therapy in their practice. Here in this slide, presenting the scenario of inadequate response to first-line anti-VEGF agents in the setting of macular edema, laser therapy, which would by default fall in the other category that is highlighted, garners less than 4% consideration. This is from 2018. In this similar survey, 1 year later, laser therapy is an optional consideration in approximately 3% of responders. Last year's PAT survey of laser use in general in the setting of clinically significant diabetic macular edema found that the majority of our colleagues use laser less than 5% of the time. In this slide, even in first trimester pregnant patients, laser use in DME is only utilized by less than a quarter of our colleagues. In 2020, approximately 1.5% of our colleagues considered laser therapy as an option when anti-VEGF therapy was inadequate in DME management. Last year, that number only rose to around 2%. In the setting of retinal vein occlusion, as expected, less than 1% would use laser therapy for RVO-related macular edema. When the RVO-related macular edema was unresponsive to Avastin, less than 5% would use laser therapy. Finally, in a clinical scenario where many of us would think that laser therapy would be a logical next step in management, less than 12% of our colleagues would consider laser therapy as an option in a DME patient with limited pharmacotherapeutic choices. So it is readily apparent that pharmacotherapeutics, specifically anti-VEGF agents, rule the roost when it comes to managing macular edema in our time. However, I will now present data that will hopefully persuade many of us here and our retina colleagues that far from being obsolete, laser therapy and specifically STL therapy has a critical role in the management of these patients. Our next section will delve into the specifics of the macular disease entities where STL and pharmacotherapy are employed. Listed here are the macular conditions where laser therapy in its variable modes has been successfully employed. Those marked with an asterisk are where anti-VEGF therapy is the mainstay. It is those conditions that we will consider here. The first category, namely diabetic retinopathy and diabetic macular edema, has long been managed by conventional continuous wave thermal laser and STL. Increasingly, STL has been applied very effectively in not only diffuse but also focal DME. Focal non-ablative treatment of microaneurysms has been reported with concomitant reduction in the central subfield thickness on OCT scans. Integration of STL and DME has also shown significant reduction in frequency of anti-VEGF administration. Interestingly, there are few clinicians who have applied more intense pararetinal STL applications in the setting of PDR and have achieved neovascular regression without aggravation of DME. Here is a partial list of references regarding the use of STL in diabetic retinopathy and DME. In one of those articles cited, Moiseev and colleagues demonstrated in a small series that significant reduction in anti-VEGF therapy was achievable with STL while maintaining comparable visual acuity improvement. Here is a graphical representation from that study showing the visual acuity improvements between the ranibizumab only control group, that's the upper curve, and the micropulse laser group. Similarly, reduction in OCT CMT thickness was achieved in both groups. The slide from that study illustrates the significant reduction in intravitreal injections between the two groups. In another study by Inagaki and co-workers, a significant reduction in frequency of anti-VEGF injections, less than 4 per year, following a single STL treatment was noted in a similar DME setting. Keeping in mind that the current average these days is 7 to 8 injections per year for DME patients. Here is their graphical representation of that reduction in CMT on OCT scanning and improvement in visual acuity. Similarly, in a more recent article published in AJO by Hutton and others from the DRCR network using protocol V parameters, the study concluded that there was similar visual acuity outcomes on average that are obtained by initially managing center-involved DME and good baseline visual acuity with laser or observation strategies instead of immediately using aflibercept. This figure from that publication represents the total annual cost in billions if all patients in the US with center-involved DME and good visual acuity were managed initially with aflibercept, laser, or observation. Clearly, you can see a huge difference which favors the laser and observation approach. This is another figure which represents the 10-year total cumulative costs in billions for different assumptions of costs of aflibercept, including if aflibercept cost $0. The vertical dotted line represents a cost per injection similar to Avastin, which is around $100 these days. Now we will switch gears to retinal vascular occlusions. STL has been employed on a selective basis for both central and branch retinal vein occlusions for several years now. Similar patterns of retinal application to conventional continuous mode laser have been employed with less intensity and have achieved comparable clinical results with less damage. Where STL is particularly effective is in mild CME cases and good visual acuity, similar to the DME data. Here is a sampling of the publications addressing STL and RVO. Again, I'm happy to share this with you and discuss after the presentation. One of the early cited studies by Inagaki and associates demonstrated sustained improvement in both CMT and visual acuity following STL therapy, with significant improvements noted particularly in patients with good, better than 20/40 best corrected visual acuity. This study, by the way, did not include anti-VEGF therapy. Here is the graphical representation of the OCT parameters and visual acuity outcomes over a 1-year follow-up. Quite impressive and sustained results. In a more recent trial by Terashima and co-authors looking at intravitreal ranibizumab and STL, they were able to demonstrate significant improvement in both CME and visual acuity, as well as reduction in intravitreal injection frequency. Here is the BCVA change over time for the two groups, demonstrating sustained, statistically significant improvements over a 6-month period. Likewise, the reduction in CMT was comparable between both groups over the same time course. Now we move on to STL and ARMD. Since the advent of intravitreal anti-VEGF agents, laser use in the setting of age-related macular degeneration has largely been relegated to either photodynamic therapy, PDT, or feeder vessel therapy, Recently, there has been renewed interest in the use of STL in both dry and wet ARMD. There are a few reports in the literature where STL application has reduced drusen in dry AMD and increased retinal responsiveness to anti-VEGF therapy in wet AMD. There also may be both a reduction in choroidal neovascularization and concomitant reduction in severe vision loss over time. The published literature on STL use in ARMD has been sparse, and hopefully we will see more published trials of its use in this condition. In terms of atrophic dry ARMD, the recent reports of drusen reduction following STL has a basis in the CAP trial. That's the complications of age-related macular degeneration prevention trial that was conducted a few decades ago. In that trial, you recall, minimal intensity application of a conventional laser did result in a reduction of drusen, but at the conclusion, there was no benefit in terms of visual acuity improvement and a trend to increasing conversion rate to exudative ARMD in the treatment arm. Fortunately, this has not been reported with the use of STL laser in the small case series published so far. In wet ARMD, Jeff Luttrell and his group reported a very interesting finding where patients who were gradually getting suboptimal results to anti-VEGF therapy were resensitized, if you will, following STL therapy. Here is an example from that paper demonstrating the promotion of subretinal fluid resorption following STL therapy in an aflibercept-treated eye. The top scan shows the extensive PED and subretinal fluid following multiple anti-VEGF agents. The second scan is 1 month following STL therapy, and the bottom scan is 4 months following laser treatment, showing significant reduction in overall exudation. I now would like to share some brief cases from our own clinic over the past 15 years to illustrate the usefulness of STL therapy in these conditions. Here is the fundus appearance of a 67-year-old male with type 2 diabetes and mild DME. The patient did not receive any pharmacotherapy and underwent a single yellow 577 nanometer micropulse laser session. Although it nearly took 2 months, his visual acuity improved significantly, and there is concomitant reduction in hard exudates as well. Here is the FA of another type 2 diabetic male patient demonstrating the reduction in vascular leakage and concomitant improvement in visual acuity following a single yellow 577 nanometer micropulse laser session. This patient had at least 5 Avastin injections in that eye prior to the micropulse laser application. This is the OCT scan of the same patient showing an accompanying reduction in CMT following the micropulse session. Here are OCT scans of another DME patient who was tried on both anti-VEGF and intravitreal triamcinolone with suboptimal results. The upper scan is 1 month following his triamcinolone injection. At that time, he received a single session of yellow micropulse laser session. The bottom scan is 6 months later. He did not receive any pharmaco or laser therapy during that interval. Here is the right eye of a 65-year-old male who sustained a non-ischemic superior branch retinal vein occlusion in his right eye. There was some center-involved macular edema and vision was 20/25-2. He received a single yellow wavelength micropulse laser session at that time. This was in October 2018. Here is the same patient at approximately 1 and 2 years later with no adjunctive laser or pharmacotherapy demonstrating normalization of the fovea and 20/20-2 visual acuity. Finally, here's a very interesting case of CSR that was complicated by a choroidal neovascular membrane in the right eye of a 67-year-old female patient. Following a series of 6 Eylea injections, we elected to apply a single yellow wavelength 577 nanometer micropulse laser in a tight grid pattern to cover the entire lesion. Here are the OCT scans of that patient at 1 and 2 months following the laser treatment, demonstrating complete resolution of subretinal fluid and concomitant improvement in visual acuity. So what are we to conclude with regards to the use of STL in the era of anti-VEGF and, for that matter, ocular pharmacotherapy overall in the management of macular disease? First off, it is important to remember that the gold standard of any therapeutic intervention in ophthalmology is to achieve the best visual acuity recovery with the greatest reduction in macular thickness in the shortest time, with the least amount of side effects, with the greatest duration, and in the most cost-efficient manner. That is the holy grail, if you will, that we all seek in our daily clinical practice. It is not laser versus pharmacotherapy, but rather how does one achieve the optimal integration of these two therapeutic modalities? The benefits of STL are multiple. They include uh, that it still remains has a critical role in the therapeutic armamentarium of macular disease, and with pharmacotherapy, it can be synergistic. Likewise, it can reduce the frequency of anti-VEGF therapy, or what we refer to as the treatment burden, and it can achieve a more durable clinical improvement in visual outcomes. It can also increase the retinal response to anti-VEGF therapy in recalcitrant cases. And it certainly has significantly less side effects than intravitreal pharmacotherapy, namely endophthalmitis, IOP elevation, and cataract formation. And it can certainly reduce the overall cost of treatment. The important patient factors that we need to consider in implementing STL therapy for macular disease include those patients who only have mild to moderate macular edema, less than 400 micron on spectral domain OCT, fovea involving macular edema with good visual acuity 20/40 or better, who really are not good or ideal candidates for continuous wave laser or intravitreal injections. Macular edema that's just threatening or involving the fovea, uh, as the previous patients, they can also avoid having intravitreal injections. Those patients who cannot receive injections or who refuse injections, steroid responders, and those that have clearly demonstrated no durable or effective response to anti-VEGF therapy, and in those patients who have had previous vitrectomies. So it is safe to say that the future of STL and macular disease is far from over and will continue to expand. Thank you.